The New Jersey Autism Center of Excellence, which is funded in part from the New Jersey Governor's Council for the Medical Research and Treatments of Autism and the NJDOH. We're thrilled to have Dr. Christina Nicolaidis back today to present for us. Dr. Nicolaidis is a general internist and health services researcher who uses participatory research to improve the health and healthcare of marginalized populations, with the majority of her current projects focusing on autism and adulthood. She's the co-founder and co-director of Aspire, and she also is the founding editor-in-chief of a peer-reviewed journal, Autism in Adulthood. She directs the Social Determinants of Health initiative, and today we are so grateful that she will be presenting research which identifies and understands the disparities in healthcare experienced by autistic adults, and will demonstrate a series of tools created by Aspire to help facilitate healthcare for autistic adults. And she'll also discuss lessons learned from trying to integrate these tools into the healthcare system. A few housekeeping notes. If you would like to ask a question, you do have to be logged into your YouTube account. You can ask them at any time, but we will address the questions at the end of the presentation. We will monitor the chat throughout, and once the session ends, it can be rewatched at any time. You can find it on our YouTube page. We'll also post it on our social media. So I'm going to go off camera now while Dr. Nicolaidis presents, and then I'll be back for the Q&A. Thank you so much, Dr. Nicolaidis, and welcome back.
Thanks so much for having me again.
Thank you.
Let me share my slides here. Okay, do you see those? Nope.
Yes, we do.
Okay, great. Okay, so thank you for having me. As you just heard, I'm a general internist. And often when I say I do work around autism, people get kind of confused. And I think that's because the world thinks of, when they think of autism, they think of a little white boy. And I'm talking about adults, and I'm talking about often women, non-binary folks, people of color, not necessarily the image of the little white boy. Today, I'm going to be mostly focusing on healthcare. I do want to make a few notes before I start. One is that thanks to the lessons I've learned from my community partners, I very much use a neurodiversity paradigm and a social model of disability. And that kind of permeates, I think, all the work that you'll hear about today, even though we won't be explicitly talking about either of those things. The other note is around my use of language. I really believe in person-centered language, which means that you use the language each person wants you to use when describing them. However, you can't really do that for a presentation when I'm talking about large groups of people. As such, I'm respecting my community partners' very, very strong preferences for identity first language when talking about autistic adults. I do sometimes use person-first language when talking about people with intellectual disability, largely again out of the preferences of many of my community partners. And then when I talk about disability in general, I sometimes go back and forth because it's I don't think there's as much of a consensus there. And again, I'm going to be really focusing today on healthcare. I would strongly recommend, if any of this, all this is going to make more sense if you look at last month's presentations, particularly my colleague and friend Dora Raymaker gave a presentation on cultural issues when conducting research with autistic adults. And then if you're interested in how we've done all the work that we've presented today, I gave a talk about Aspire and community-based participatory research with autistic adults that really focuses more on the backdrop and the how we partner together and how we conduct the research. So, as I mentioned, I am the co-director of the Academic Autism Spectrum Partnership in Research and Education, or Aspire. Dora and I co-founded Aspire back in 2006, and we've been incredibly fortunate to have built this great group, now originally nationally, now international group of autistic adults academics, family members, disability services providers, healthcare providers, and obviously many of us wear multiple hats. Those aren't mutually exclusive groups. We use community-based participatory research where autistic adults serve as equal partners throughout all phases of the research projects. Um, I always gave, when I would start talks specifically geared towards healthcare providers, I would often start with a message from one of our long-term Aspire community partners, Mailbags, who, sorry, who was particularly passionate about the importance of healthcare, who worked very hard on creating a lot of the tools that I'll show here. Mel unfortunately passed away this year, but if we can just play this little clip to get us started, and then I'll read more of the message that she wanted to give to healthcare providers. Hello. I'm sorry. The the clip, I'll just play it without the sound. It's basically, so yeah, Mel gave lots and lots of words of wisdom to healthcare providers. This is a very short excerpt of one of the things she had asked me to read out loud in other talks. She says, "I'm Mel. I'm 37. I'm both autistic and someone who needs frequent contact with the healthcare system, whether I like it or not. The most important thing is we're human beings. Listening to us, even just one doctor listening to us, can help us. I wouldn't be alive if I hadn't been very tough, very lucky, and had a lot of people pulling for me at times when people really didn't want to give me health care for bizarre reasons, including that I was just inconvenient and annoying and not very valued as a person, or that people thought I was pretty much the living dead, so prolonging my life would just be pointless. I can be horribly inconvenient if you're not prepared for me. When you get that inconvenient person, that annoying person, that person who seems crazy, that person who seems like they don't get what's going on, the person whose abilities change, that person who has so much going on, you figure if that were real, it would have been diagnosed by now. Remember that we're all human beings. We all deserve health care. Often we turn up with things that are more typical of people in countries without medicine because we get so much medical neglect. That's people with developmental disabilities in general, probably also psychiatric disabilities. Each of us is different. That's why we did the toolkit. The toolkit helps people talk about specific issues that are different for all of us. Every time I nearly dive and survive, I know that means other people didn't survive. I wrote this so that more people will survive." So Mel is talking about some very real healthcare disparities. Um, Our very first study back when we first started Aspire was actually looking at some of those disparities, not necessarily because it was surprising, but because no one had ever documented them. So then when we would go and, and ask for funding to do something about it, people would be like, but wait, how do you know? So we had done an early online survey comparing the healthcare experiences of autistic adults to non-autistic adults. And surprise, surprise, the autistic adults have more unmet healthcare needs. We found that they had a greater number of unmet mental health care needs, and greater unmet prescription medication needs. They also had greater use of the emergency department, which often really is a proxy for a failure of the primary care system. And they had lower use of preventative health, such as the use of pap smears. And again, not surprisingly, they had lower satisfaction with patient-provider communication and on healthcare self-efficacy. And this was a very early study, and was just a convenience sample. But this has been replicated in larger samples. For example, our colleagues at Kaiser did a larger case control study comparing autistic adults to adults with ADHD. And again, the autistic adults had a greater healthcare utilization, but lower preventative healthcare. And the differences were greater, were even greater when they compared autistic adults to the general population. Saying there are disparities isn't very useful unless we can think about what to do about them. And one first step is figuring out, well, what are the barriers to healthcare? So this is an analysis led by my colleague, Dora Raymaker, where we use data from that initial Aspire Online Healthcare Survey and looked at specific barriers. There were many. People without disabilities generally experience far fewer barriers to healthcare than either autistic adults or people with other disabilities. But when just comparing the autistic group to people with other disabilities, the autistic group reported more barriers to healthcare, and a kind of somewhat different pattern. Again, there were many barriers, but the top ones often related to fear or anxiety, not being able to process information fast enough in real time, concerns about cost, facilities causing sensory issues, and difficulty communicating with providers. So we talk a lot about providers, and in this particular case, I have to say, I was just saying, I have to say it's a little daunting because normally I know who I'm talking to, and normally I know I'm talking to a group of physicians, or I'm talking to a greater self-advocacy group. I don't know who's watching this, so I'm going to tailor my comments to both. People are always thinking that providers don't know what they're talking about when it comes to adult autism, and the truth is that's the case. Not because of a lack of intelligence or caring or anything else, but this is a topic that is not well addressed in healthcare training, especially for people who provide care to adults. We had done a small informal survey years ago of internal medicine and family medicine providers who care for adults, and 73% felt uncomfortable in their ability to provide quality care to adults on the spectrum. Still, 84% of them had no plans to seek additional training on autism. Again, not because they're bad people, but because this is hard to fit into an already very, very challenging job. Interestingly, even though they felt uncomfortable and even though they didn't necessarily have plans to seek additional training, the vast majority would accept an autistic adult into their practice. And even with that, accepting an autistic patient into their practice, the majority still didn't have plans to attend continuing medical education. They did, however, say that they would search the internet for information, and they almost all said that they would happily read customized reports, which is largely why we've created our toolkit the way we have. Again, our experience has been replicated. Again, in the Kaiser group, they did a much larger study of almost 1,000 healthcare providers. And you'll notice that regardless of training in medicine, OBGYN, or mental health, the vast majority of providers really rated their self-rated their knowledge as poor or fair. More recently, we again surveyed primary care providers before we started one of our interventions. And this time we included 143 primary care providers in California and Oregon. And you'll notice that a minority feel that they're confident in communicating with patients, with adult patients on the spectrum, performing exams and procedures, treating co-occurring conditions, or helping their patients stay calm. And most importantly, practically none of them felt comfortable in identifying and making accommodations to be able to facilitate care. So why is that? As I said, this is not out of a lack of effort or caring. It's really hard being a provider. I'm going to say this as I had been in primary care for 15 years and have pulled back from that. I still practice hospital medicine. It is challenging. It's been very hard to get autism training into medical nursing school or residency curricula, partly because there's currently no training requirements and because these curricula are extremely crowded. There are a few model programs that really do build in training about autism or other developmental disabilities, but those are very few and far between. And then a lot of what we learn often really comes from practice and from continuing medical education, but there are many competing priorities. I have to say, because I work with a lot of pediatricians, I often get this idea that, oh, the problem is all about transition, and the problem is we just need to, give adult providers the training. I think it's more complicated than that. When you're a pediatrician, a chunk of a pediatrician's practice is taken up by children with special healthcare needs, children with developmental disabilities, autistic kids. That's kind of front and center in a pediatrician's practice. The cohort of children that were diagnosed in the late 90s, early 2000s is just now making their way into the adult healthcare world. Not that we don't have adults of all ages, but this is the group that's been recognized. This is the group that's had the most attention to them. But okay, now they're in their late teens, early 20s. We don't, as internists, see 20-year-olds very often. Most of our day is taken up by congestive heart failure and diabetes and lung disease and really more middle-aged to older diseases. Or to diseases that middle-aged and older people tend to have. So our day is actually filled very differently. And even if I'm just not thinking about autism, such a tiny proportion of our attention goes to that. When I give talks about chronic pain, it's standing room only. When I give talks about autism, no one shows up. And that's just because this hasn't yet become the issue that it really needs to be. It's very hard for providers to focus a lot of attention when there might be one or two patients on their panel. For that individual patient, it is absolutely critical that healthcare providers learn that. I want to make sure that as we move ahead and as we try to train providers to do a good job with adult patients, that we don't oversimplify how easy it is. a lot of what we've done is try to do to create tools and instruments that can help providers with an individual patient without necessarily pretending that they're going to be able to know everything there is about autism. So, what about the patients? We've we did a qualitative study with 39 autistic adults and 16 supporters, really focusing on what is their experience of healthcare and what do they feel the healthcare system can do to better improve their care. Um, we found that interaction. Patients would often talk, autistic adults would often talk about patient level factors, their own verbal communication skills, sensory sensitivities, challenges with body awareness, etc. These are all, you would expect this if just from the definition of autism. On the other hand, those patient level factors weren't by themselves what was driving the success of the healthcare interaction. It was an interplay between the patient level factors and the provider level factors. And this is where, again, it's so important that the providers better understand how to what autism looks like in adults, think about their assumptions, their willingness to communicate in other forms or to use accommodations and so on. And of course, we work in the context of the larger healthcare system, which I don't need to tell you has plenty of problems in and of itself. So here are some of the things that we thought were most important for healthcare providers to think about and understand when paying attention to when taking care of autistic adults. One is sensory sensitivities. This is a quote from a young woman who said, "The lights in the office are very bright, and that is exacerbated by the white walls. Sometimes the waiting rooms are crowded, and I cannot filter out the background of people talking or shuffling magazines. I feel disoriented by being led down long hallways to different rooms. I'm not able to bring up my concerns because it is all I can manage to figure out what the doctor is saying so I can respond to his questions. But he refills my usual meds and I go on my way." If we're aware of sensitivities, there's things that we can do. We can use natural light, turn off fluorescent lights, make the lights dim. We can try to see the patient in a quiet room, trying to minimize unnecessary stimuli, thinking about how many people are talking at once, warning patients before you touch them. Similarly, a lot of participants brought up challenges with body awareness. For example, like when they ask if pain is shooting or stabbing or burning, it's like, I don't know, it just feels funny. Or another patient said, "The problem is that it's difficult for me to isolate specific sources of pain and identify duration and intensity. It's sort of like the equivalent of white noise." This is where it's important for us to just at least know this. Consider the possibility that differences in body awareness may be affecting how a patient recognizes or describes a symptom or how a patient responds to illness. And I've spent a career trying to get people to not do unnecessary testing. On the other hand, in some circumstances, we do need to do additional testing or imaging if we really don't have a reliable history in physical. Unfortunately, patients frequently talked about providers' incorrect assumptions in really both directions. For example, I have used an Alpha Smart when my speech is too slow or difficult to understand for medical appointments. Some of the doctors have been really great, but others have acted really condescending when I used it, also immediately assuming I couldn't be alone, had to have my parents there too. So I try to go without, even when my speech is in a poorer shape. Or conversely, usually, when I demonstrate a large vocabulary or some fundamentals, my needs, especially around communication, are then ignored. My choice is then to pretend to be less intelligent and accept their infantilism, or to be confused, frustrated, and stressed out. Along the same lines, it was very saddening to hear how often providers refused to really think about or make needed accommodations. For example, I prefer and find it easier to communicate in text, but with every doctor I speak to, they wave away the note card and look at me to ask the same question I've just answered and interpret my confusion as my being non-compliant with the medicine. I wish healthcare providers would read the notes I make for them. So autism is a communication disability. Um, we really need to be thinking about our own um, communication. Check your assumptions. Just because somebody can speak does not mean that they necessarily can speak, can communicate or understand what's being said. And just because somebody cannot speak does not mean that they can't think or cannot be included in the in shared decision making. Use the patient's preferred communication mode, even if that seems strange. We're very much taught in a way that everything has to be verbal, and we tend to not really pay attention to written materials. This is a case where I think we really do need to um, read what patients write. Be very concrete and specific. Avoid open-ended broad questions. I say this after having just gotten off of an attending block where I was hammering into my students the importance of asking open-ended questions. In this case, we actually may really need to follow up with very precise, specific questions. And don't force the patient to make eye contact. It's again something that we're taught is the way we connect with patients. It may be uncomfortable or hinder effective communication. We also heard a lot about difficulty with planning, organizing, and sequencing some of the quote executive function skills. This participant said, I wish they understood how easy it is to get confused with all the administrative hoops a patient has to jump through to get help. It sounds pathetic at my age, but I need someone to hold my hand. I don't know what I'm doing, but nobody understands that I need that, and there's definitely nobody willing to do it. Again, this is where we need to sometimes write out detailed step-by-step instructions, and this is where we can bring in our teams and where care coordinators and panel managers and social workers and other people can really help take a more active role with care coordination, not just making the assumption because somebody seems like they're living independently that they can necessarily manage the healthcare system without additional support. And then lastly, we heard a lot of frustrations about patient autonomy. As this participant says, just because I might need more information to understand things, it doesn't mean they can or should just talk to me like a child or leave me without knowledge of my own health. My body is my body, and my experiences and wishes about my body are mine to make. This is so important and so hard for us sometimes to remember that patient autonomy is just as important regardless of where somebody might fall in terms of the particular skills they may have in communication, in health literacy, or in anything else. So I'm going to move now from telling you all about what a terrible problem it is to telling you what we've started to do to address parts of it. The basic idea is that autism is a very, very heterogeneous condition. There's an adage of when you've met one autistic person, you've met one autistic person. And this is where I am afraid that if I just kind of give you these generalizations about autism, they may or may not translate into what an individual patient needs. So we've tried to focus on individualized tools. Our partnership over many years worked together to create the Aspire Healthcare Toolkit. Every piece of this was co-created with our autistic community partners. They wrote parts of it. They've certainly edited parts of it. What went into it came from both our qualitative work in our surveys and also from our partners' lived experiences. The healthcare toolkit has two parts. There's a part for patients and supporters and a part for healthcare providers. The provider information really focuses on practical tips for successful office visits, as well as lots of other kind of basic information about autism and resources and links. The patient information side has a lot of materials around finding healthcare providers, navigating the healthcare system, as well as many other topics. You'll notice that format, and you'll notice that's in great detail. Oftentimes, what our partners said was that they knew the big idea of how they should do it, but they needed a script on what to say when you called an office or what to bring with us. So it's very much built with a ton of specificity and a ton of examples to help people try to better navigate the system or manage their health care. And then we have a bunch of forms and worksheets. These are tools that, again, are largely trying to help autistic adults and or their supporters better advocate for themselves. There's a worksheet for making appointments, a checklist for what people may want to bring to a healthcare visit, a symptom worksheet, which helps people think through how they're going to potentially describe what's going on. I'll give you a little secret. The symptom worksheet is really the same overall idea of what we teach when we teach medical students how to do a history and physical. We teach them how to take a history of present illness and the different elements that we want them to collect information about. This form was built very much the same way as we teach medical students to collect a history. The idea being that if people can, in their own time and in their own space, think about how they're going to describe the problem in a way that matches with how providers are taught to think about a problem, that doesn't have to happen in the anxiety provoking situation of being right there in a visit, answering questions in real time. We also have a worksheet about what to do after the visit to try to make sure that people have the best chance of following up on the things that they're trying to do. And then the centerpiece of the toolkit is what we call the AHAT, the Autism Healthcare Accommodations Tool. This is the patient and again, or their supporter fills out a survey, and the computer uses the answers to the survey to create a personalized and healthcare provider friendly report of accommodations. You'll see that it's the AHAT uses this great audio computer assisted survey tool that can read out loud and can change font sizes and can really present things as clearly as possible. And then patients are asked to pick the accommodations or strategies that would best meet their needs. The reports then come out with kind of bulleted, action-oriented type statements that really can help a provider make accommodations for this particular patient. One patient may choose an accommodation that's talking about needing very simple vocabulary and short sentences. Another patient may choose an accommodation about using very precise language, etc. Again, I'll tell you a little secret. We did a bunch of testing to come up with what to put into the AHAT, and then to make sure that it was understandable and useful. The patient side of it went swimmingly. I mean, patients and supporters generally found that this was covering what they wanted, and this was easy to understand. It took us about a dozen versions to get a provider report that met the provider's needs. Because as much as we think about patient accommodations, we also need to think about provider accommodations. And again, I've been there. You have to see a patient every 15 minutes. Reading a long report is impossible. So we've really tried to come up with formats that can make the information as easy to find and as quick to find for providers who really need accommodations because they're just too busy and stressed themselves. We have been testing the toolkit now for a while. Our initial evaluation was just a preliminary pilot test. We used a mixed method, single arm, one month pre-post intervention study design in real life settings. We recruited 170 autistic participants, as well as 41 of their primary care providers. The vast majority found it easy to understand, important, and useful. And when we compared participant survey answers from before using the toolkit to a month later, we found statistically significant and clinically significant changes between in the number of barriers to healthcare, so lower numbers of barriers to healthcare. We found increased healthcare self-efficacy, meaning confidence to manage the healthcare, and increased satisfaction with patient-provider communication. In open-ended parts of the survey, we found some strong qualitative themes around why the toolkit may be useful. A lot of people felt that it was kind of a means to clarify and communicate their needs, sometimes things that they hadn't ever really put into words, what the problem was and what might fix it. It often validated their experience and empowered people to better advocate for themselves, and it improved their ability to prepare for visits. We also heard lots of very nice concrete examples of ways that providers changed their behavior in response to having received an AHAT report, and that both patients and providers really appreciate it. Then gets the harder part. We had another grant to integrate the toolkit into 3 healthcare systems, Kaiser in Northern California, and then Oregon Health and Science University, my own institution, and Legacy Health System. I'll tell you, that was a challenge. And we found that, again, people liked the toolkit. They found it useful. They appreciated it. But we had a lot of logistical challenges in actually this nitty-gritty stuff that was boring and critically important. It was very hard to get the reports to the providers when they actually needed them. By the time they saw the patient, oftentimes they didn't even remember they'd seen a report. Because the study came from the institution, patients assumed that the providers would know about all this, when in fact that wasn't the case. We have lots and lots of lessons learned, and I'm not pretending that this is kind of all fixed. However, there was a lot of promise in there, and there was a lot of very concrete suggestions of how we can potentially integrate these tools in a more effective way. Now we've got the honor of collaborating with Dr. Jeremy Parr's group in the United Kingdom, where we're combining an adapted version of our autism healthcare accommodations tool and some of our other tools that are on our in our toolkit with an annual health check that will be happening with autistic adults. And this they're actually planning on doing throughout the entire national health system in the UK. So I'm hoping that, again, combining these tools with an in-person visit and with our joint forces may potentially give us newer and better directions to go in. There's lots of work to be done in the United States, and I'm hoping to kind of bring back what we learn in combination and figure out how to do it in our more fragmented, more problematic health system that again needs a lot of work. In the meantime, the toolkit is available for free to the public. We have, I love getting little emails from people randomly saying, hey, I used this, and my provider actually, this was the best visit I've had with my provider. It's very, very rewarding to see that it is getting used, and that people do find it helpful in an individual one-on-one basis. We'll keep working on the systems. Speaking of systems, as I mentioned, I was a primary care provider. More recently, I've been working primarily in the hospital. Hospital and emergency department care can be even more challenging because all the things we just talked about in primary care get harder in an emergency or an acute situation. Was very pleased to have Dr. Anna Urbanowitz from Australia come spend 10 months with us over a year ago as a Fulbright scholar. It was lovely to have her with us in Portland as part of the Aspire team, and we continued to work with her, and she's now starting a lot of Aspire work in Australia. While Anna was with us, she conducted in-depth interviews with 42 participants, including autistic adults, hospital providers and staff, supporters, and key informants about their experiences in the emergency department and in the hospital. And then we've conducted a thematic analysis, again, using our CPPR approach. These are just preliminary findings. We're close to finalizing them. But again, not surprisingly, we again saw a lot of themes around providers' lack of knowledge and experience in autism. And coupled with that was just how inherently autistic unfriendly hospitals are. Just about everything that has to do with a hospital is the recipe for making something challenging for autistic adults. Again, we heard that in the end, being heard, being included in making decisions is really necessary for high quality hospital care. And I really do think that critical middle piece is successfully identifying and meeting accommodations. And where we saw that people were having accommodations met, hospitalizations went much better. There were unfortunately many, many examples of where accommodations would be possible but weren't being put in place. Anna and the rest of our team will be working on trying to adapt the healthcare toolkit for hospital settings. Our participants gave us lots of ideas of things that would need to be adapted and things that can make the toolkit more useful in a hospital setting. That being said, as a hospital provider, every time I have an autistic patient on my service, or even when I have patients with other disabilities that aren't necessarily autism, but that have potential accommodation needs or communication issues or anxiety or health literacy issues, I do informally use the toolkit with my patients, just understanding that it's made for a different context, but it's still, I think, quite helpful to have some of these things spelled out, because we just don't think about them when we're trying to deal with an acute illness, often a life or death situation. We tend to put the autism to the side when in fact that needs to come front and center, because good communication and being able to tolerate a hospital environment are really critical to being able to treat the whatever illness is bringing them into the hospital. So how am I doing on time? I'm going to very quickly focus a little bit on reproductive health. This is because we often forget about it. We as a society tend to desexualize people with disabilities. So it just doesn't even enter our radar. Most studies of sexual behavior in autism unbelievably use parent report. I don't know about you, but I don't know how many of us would have had our parents give adequate report of what our sexual behaviors or knowledge or attitudes were when we were young adults. We know that parents say there's greater discomfort in their communicating about sex with autistic adolescents. There's a tiny small literature assessing sexual health directly among autistic adolescents and adults. And that literature, people self-report having lower knowledge, greater concerns, and higher rates of experiencing sexual abuse. Um, we did a small study led by my colleague Mary Oshwald about pregnancy, disability, and women's decisions. This was again a qualitative study with 51 women, a majority of whom had intellectual disability, and then 17 of them were on the autism spectrum with or without co-occurring intellectual disabilities. This didn't use a full community-based participatory research approach like our Aspire studies, but we did have a community advisory board of autistic women and women with intellectual disabilities. In the interest of time, I'm not going to go through these as carefully, but many participants described struggles with abusive partners, past trauma, poverty, substance use, legal system, health complications, etc. This really was not separate from the autism and the disability. It was really hand in hand. And we know that social determinants of health make a really big difference. They don't get forgotten here just because we're talking about autism or intellectual disability. We found a lot of quotes around isolation, being apart from strong social support networks, disability and motherhood themselves potentially being isolating, and women often feeling they needed to keep their decision making private. For example, this woman said, I just felt really like alone and depressed all the time. I couldn't really talk to nobody. I didn't really have the supports. I had the supports of finding stuff that I needed sometimes, but the supports of talking to somebody about what's going on, and how I'm feeling, we also heard a lot about discrimination, lots and lots of stories of ableism, racism, sexism. Many feared that their children would be discriminated against if they had the same disability. Um, um, and again, the social expectation that women can become mothers. So basically, there were social expectations in both ways. Sometimes it was that being a mother is normalizing if they chose to have children, and sometimes that they're discriminated against it if they chose not to have children. I thought this was particularly important to bring out because we sometimes accidentally reinforce ableism within healthcare. As I mentioned, we use a social model of disability, and in general, I try to stay away from a medical model of disability. But I'm a medical provider. I don't refrain from using a medical model for medical conditions, many of which might be co-occurring with disability. The problem is it gets tricky when we put those two together and we don't always think about how we talk to our patients and how that gets interpreted. For example, there's just the language and all of the paperwork and questionnaires around genetic testing is like incredibly offensive. I mean, they refer to everything as birth defects rather than developmental disabilities. It's like the entire infrastructure is set up to discourage women from carrying pregnancies to term if there's any possibility that the child will have a disability. And that there's this implicit bias in the language in all the conversations about pregnancy that is all about fear of disability. And disability is like the ultimate tragedy that we're working together to avoid. I was just much more aware of that climate, especially because I'm 42, so obviously there's a lot more genetic testing and stuff that's recommended when you're pregnant at this age. And I'm autistic, and I have a child who's autistic, and I have physical disabilities, and some of those are genetic. And like, there's a very, very high chance that this child will have some disability or another. And I don't fucking care. Like, that's not important to me. We also heard a lot about independence and resilience. This was extremely important, and I think important for us to remember. Some women were put under a lot of pressure to have a child, to abort a child, to otherwise do what everybody wanted them. It seemed like no matter what it was, somebody was trying to force them to do something. However, most women described making their own decisions, even when others disapproved, and they often really had a very strong sense of pride about their self-sufficiency in their decisions and their lives. For example, I was extremely stubborn, and when I make a decision and I want something, I'm not going to let somebody stand in my way. I was not going to have an abortion, and nobody was going to tell me what to do. So regardless of how anybody in my household, the people I lived with, or anybody felt about it, it did not matter to me. You cannot tell me what to do with my body. We also found that, really the stories weren't so different. Women described motivations for their decisions to become or not become pregnant that weren't really that different from any woman's decisions: desire for family, biological age, experiences with children and babysitting, coping with grief, etc. We had gone into it thinking that a lot of resources were going to be in terms of how to find prenatal care or how to find the right provider. And that turned out not to be as much of an issue for at least our participants. Most of them knew where to look for resources. Most of them were already connected to groups such as WIC, Women, Infants, and Children, if they needed them. But they had many other needs. They talked about needing accessible pregnancy and mothering training programs. They really wanted interactions with women like them around pregnancy and motherhood, knowing what the reality of pregnancy and motherhood is really like, and accessible education on birth control, family planning, and decision making. We worked with our community partners and with some of our study participants to figure out what it is that we could put together. And we collectively decided to make some videos related to some of the key findings. These were scripted and created in collaboration with our entire team, as well as, again, participants from the research study. Now, these are not Oscar-winning videos. My son, who is a film critic, would totally disapprove, but I do think they're quite helpful for people with intellectual disabilities, for autistic people who are thinking about pregnancy or considering pregnancy, to have somebody to that they can hear from, that can potentially talk about their own experiences and lessons they've learned. And now we're working with our colleagues, in particular Dr. Willie Horner Johnson, to develop and test a pregnancy decision aid that would take this work further. So I've thrown out a lot of stuff over a decade worth of work that we've been doing about healthcare for autistic adults. A few basic take-home points. Autistic adults absolutely currently experience significant healthcare disparities. Unfortunately, the adult healthcare system is just currently not well equipped to manage autistic adults' needs. We know there's a big gap in provider knowledge and skills, a lot of real barriers to filling those gaps, many barriers to care, some of which are potentially modifiable, but we need to do the work to figure out how to actually decrease those barriers to care. And interactions aren't a one-way thing. Successful interactions really depend on addressing patient, provider, and health system factors all at once. Our Aspire Healthcare Toolkit is a first step towards improving care. I'm not pretending it's going to answer everything, but I do think it gives patients and their supporters some very practical tools to self-advocate and to prepare for visits and to be able to manage their health and healthcare, and I think the AHAT reports really give actionable advice to providers about what they can do for this particular patient that's in front of them. And no matter what you say about providers, most of us do care about the patient that's in front of us and do want to do the best job we can to try to facilitate their care and give them the best care we can. Um, Many more solutions are needed at the patient level, the provider level, at the system level. We're going to keep working on it. I hope others continue to working on the issue. I hope that when I'm giving this talk a few years from now, I can paint a much rosier picture. But in the meantime, I'm very, very grateful for those of you who care to try to improve things the way they are now. Again, to reiterate, we have a variety of resources. I've mentioned our healthcare toolkit and the pregnancy videos. We also have a bunch of collaboration tools around community-based participatory research. And of course, many thanks to our Aspire Healthcare team, the Pregnancy Decision Project team, and our funders, especially the NIH and the Fulbright Foundation. And I'll take questions.
Thank you so much. I feel a mixture of very terrified and also hopeful that you're all doing what you're doing. I see, as a parent, my daughter is still on the younger side, but obviously I know, she's going to grow into an adult. I was reading recently that a lot of people still see pediatricians as adults. Is that the case?
Yes, and that works for a few years. And we do have a lot of young adults still seeing their pediatricians. The problem is that pediatricians are pediatricians, and
Right.
pediatricians do amazing work as pediatricians, but they don't know how to take care of the diseases that we take care of. This isn't a sustainable solution.
Right.
They're seeing 20-year-olds, okay, but are they going to be seeing 60-year-olds?
Right.
Like it's, and we really do. We have a lot of patients staying with their pediatricians. I have lots of pediatricians. I mean, I get emails constantly from pediatricians saying, okay, like, where do I send my patients? They're getting too old for me. And we have pediatrics departments actually putting limits. We have, I mean, not just for pediatricians, for psychiatrists. We have a situation where we had a psychiatrist who was seeing patients in the pediatric in the pediatric clinic that were of all ages. And now they're saying, wait a second, no, you really have to limit at least to the mid-20s, not further. So we do need to create ways for adult providers to take good care of patients on the spectrum. I think we're making headway. You're talking about your child is still young and someday they'll be an adult. I started doing this work when my child was 4. And I would joke, people would be like, well, why are you doing it? I'm like, yeah, it's going to take that long before we make any difference. My child's now not a child. My son's an adult.
Yeah.
And we've made headway. We've made a lot of headway. These things weren't talked about. You know, when we started, this wasn't even like, there wasn't a paper on it. Like there was, we made headway, but it takes a long time. And I am worried about this generation that is now reaching the adult world. And I'm even more worried about the 50 and 60-year-olds that never got the attention because they've been forgotten all along. Again, I don't mean to paint a terrible picture. I do think there's been progress. I do think that we can do a better job. And again, whether or not I have the evidence base that I'd love to have right now, I do see that there are tools that I personally can use that make it easier. I have lots of patients, colleagues, friends who really do see that by making even small accommodations, we make really big differences.
Yeah. I've seen health systems do trainings for like the LGBTQIA communities, as like a cultural training that they need to know these things because they're going to have patients, who are in that community. Isn't getting autism training very similar to that in a lot of ways?
Yes, and I don't think as a medical profession we think of it that way.
Mm,
We think of, I think, and I love that we are doing LGBTQIA trainings, etc. And those are often an in because there's such a high overlap between autism and gender nonconformity that it's actually it's the providers that are doing gender dysphoria
right.
treatments, and the providers that are actually in the trans clinics are the most open to hearing about autism because they recognize that a lot of the portion of their panel are
Yeah.
autistic. So there are real overlaps here. Yesterday online, if you're interested, Dora Dora did an interview with Nick Walker, um, who um, who talked very much about the overlaps between neuroqueering and gender queering. And so again, that's just online on our journal as of yesterday.
Oh, wonderful.
It's free for this month. There are many overlaps there.
Mhm.
And as a society, we have long ways to go when it comes to LGBTQIA issues,
Yeah.
but at least we recognize that this is a cultural thing. We recognize that this transcends wherever you are in medicine.
Right.
We don't yet recognize autism or other developmental disabilities, or even just disability. We
Yeah.
don't recognize it as a cultural issue. We don't recognize it as something that fits into that category. We think of it as this condition that has this, tiny prevalence. Not really, it's 1 or 2%.
Right.
We think of it as this kind of rare condition. And then in the adult world, we think of it as an even much, 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 much more rare condition, largely because a lot of people haven't been diagnosed, and largely, as I said, because our day gets filled with medical conditions.
Right.
The more people can think of this as a cultural issue, as a communication issue, as a social issue, the more I think we're going to do, not only in getting people interested in learning about it, but in actually being able to provide good care. We're very much in the minority on this.
Yeah. Yeah. One of the comments we had says, so true regarding communication. My son is non-speaking but understands every word. He uses AAC and sometimes this is perceived as childish. And I I was thinking also of something that Dr. Kripke had said in her last presentation, which was the importance of providers in what they are writing in a patient's chart about how they communicate. Do you want to just speak to that a little bit, if you would?
Yeah, I mean, it's in both directions. There's the how we actually try to communicate, and I'm appalled at how underused AAC is.
Yeah.
And this isn't just in autism. This is in disability. I not this last the when I was attending in the beginning of the pandemic, I was taking care of a gentleman who had a spinal cord injury, was on a ventilator, had been on a ventilator for a year and a half, um, in and out of rehab, in and out of physical rehab, in and out of hospital systems, is on a ventilator, couldn't speak. No one had offered him AAC in a year and a half of this.
Oh,
And his family could lip read because they knew him really well. This was the pandemic, this family wasn't there. And suddenly, for the first time, people are panicking because they can't communicate with him.
right.
So this isn't just autism. This is we just underutilize AAC. Um, it it didn't take very much to get him started on a path to AAC. Um, it shouldn't be this random thing that you happen to get hospitalized for your pneumonia while the attending internal medicine physician happens to do autism research for you to be given an opportunity to use AAC.
Right.
That's not
Right.
the way it should work.
Yeah.
So yes, we completely underutilize it. We don't even write the right orders. When I spoke to the speech language pathologists that were on the case taking care of his trach, and I said, "Oh, I guess we need to bring in an AAC person." They're like, "Oh no, here we've got all these tools." And I was like, "Well, why haven't you been using these tools?" "Well, the order was for trach management. It wasn't for AAC."
Yeah.
Um, so we need to all, I mean, we wherever we are in this, we need to really be thinking about communication and how do we really help improve communication, whether it's short term, long term, whatever the disability is. The other part of your question is what we put in the chart. And what we put in the chart, oh my gosh, people like we write to each other in all sorts of bizarre ways in medicine. I'm not gonna, I don't, I do a lot of work in making things accessible. I'm not gonna start making my medical notes accessible to the world. They are in that they're gonna be, as of next week, at least in our health system, our inpatient, notes will be accessible to patients. I'm terrified because I cannot make patient-centered accessible notes. That's not going to happen, but we can make respectful ones and we can make accurate ones. And there's a difference between how we talk to each other in our bizarre little gibberish that is meant to be communication between providers. And I don't apologize for that. I'm going to communicate with another provider differently than I might communicate with somebody outside of healthcare. I do think, though, we need to be respectful. We need to think about what we write that is stigmatizing or harmful.
Mhm.
We need to know what we write that then puts people in a mindset that almost predisposes them to give poor care. So yes, the more we can accurately describe patients' communications and preferences, again, whether we do it in our notes or whether there's a whole section of it on the AHAT, that's actually why we have that section in the AHAT, so that it can get into the medical record. So it's clearly documented how a patient communicates and what's useful for them in communicating. These are really, really, really important and forgotten. Again,
Yeah.
it's very easy for people to focus on the medical problem and talk to a supporter, or um, or make really bad assumptions about what the person can or cannot do based on how well they can or cannot speak.
Yeah.
Um,
Yeah. It's definitely something that is always there, and hopefully little by little it's going to continue to get better. Um, the one other thing I wanted to ask you was about telehealth. My We just used it the other day, and obviously you can't telehealth won't necessarily work for every appointment, but what I liked about it was that I didn't have to stress her out by going into the office. Um, it was very easy for her to tolerate that. Obviously I was supporting her. Do you think telehealth offers any potential long-term benefits? Or like, what are your thoughts on that?
Absolutely, absolutely. And of course, as you say, it's not the panacea.
Yeah.
One thing, I mean, for all the horrid things that have come about because of this pandemic, one thing that I've heard many times from my autistic friends and colleagues is that it basically showed that all these things they've been asking for and begging for and pleading for a very long time, and they've been told are not possible, are in fact possible when the dominant population needs them.
Yep.
Um, and it's both frustrating and great because, and these are things that the autistic community has begged for a long time, whether it's telehealth, whether it's remote work environments, whether it's remote education environments. There are many, many things that are being done now that were specifically like, I need this accommodation, this cannot happen. Now they are happening. That is great. I hope they continue to happen when they are, when
Yeah.
we are in in a better place and we don't need them for everybody.
Yeah.
And I don't want to make the assumption that they work for everyone. Partly, as you say, I mean, again, as I practice hospital medicine. I don't have a remote option. Like when people are sick and they need in the hospital, they need to be in the hospital. You
Yeah.
can't do everything
Yeah.
remotely. Even in an outpatient setting, sometimes you need a physical exam, you need a lab. Like, we're not going to do everything remotely. And just because they help some autistic people in some situations doesn't actually mean they help all autistic people. And
Right.
it gets back to that heterogeneity,
Yeah.
where on the one hand, the remote, the written, the not having to be there is so helpful for some people and for some situations. I also, again, in my personal life, have seen um, autistic people who have actually had a much harder time participating in educational activities, in healthcare, in social activities, because it's remote.
Yeah.
So,
Oh, yeah.
so again,
Absolutely.
I just get back to that same, underlying principle of all of this is patient-centered is individualized, and
Yeah.
it's different things are helpful to different people under different situations and different circumstances and for different reasons. But I am very pleased that we've increased our options for telehealth, both for autistic patients and for the rest of us. I've been getting plenty of my health care remotely, and it's quite convenient. I'm fine to continue with that. But yeah, we'll see how it plays out when it becomes, again, something that's a quote special need as
Right.
opposed to
Right.
for everyone.
Right. Well, I appreciate your tools so much. I, I just thinking about how many people you help with these tools. It's just thank you. Um, and we'll make sure that we post those in the video link. If any physicians are watching and you have more questions, like please feel free to reach out to me, and we'll try to connect you with any resources that we can. It seems like a lot of this is going to be a little bit grassroots in a sense, where you know individuals and families are kind of taking these tools to their providers and kind of being like, you know, we can do this.
Yeah,
um,
I hope it is. I hope that someday it's the other direction and that it's the systems rolling them out. Um, but for right now, I have more faith in patients and families bringing them to their providers, or an individual provider saying, oh, here, this might help with this patient. We're working on the system side, but again, that's going to be the long-term solution. But systems are hard to change.
yeah. Well, thank you for trying, and we'll get there. Um, we again appreciate you so much, and we're so excited for Dora to come back next week to present on autistic burnout. You're both brilliant, and thank you again for being here.
Thanks for having us. Thanks for all the great work you're doing.
Thank you.